Hello. Did we go live? Let me see. It's always an adventure trying to go live. All right, we are live on YouTube. Let's check Facebook here. We are now live on Facebook. Let's see here. Hold on one sec. Are we good? Yes, we are good. Hello, everybody. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, June 26th. I cannot believe how quick time passes. It's crazy. Am I right? I mean, like, seriously, yesterday it was May. Yesterday was March. It's amazing how quickly time goes by for us these days. So it is time for another live interstitial cystitis support group meeting. I was not able to do it last weekend because I had stuff. Yeah, I will say, for those of you who know me, you know that I have been struggling with headaches for the last year and a half. Finally had a CAT scan, and guess what? It's a root canal gone bad. I had a root canal go bad that was causing all these terrible sinus pains. So the great news is that it got fixed on Monday. I'm feeling massively better, and life can go on, and it's time to get back and doing the work that I love to do, which is giving you IC support. And of course, massive things have happened. So we have a ton to talk about. But before we get there, just to let you know, I normally stream twice a week. I do on Sundays. I do a live stream on YouTube and Facebook. So we are live streaming right now. So if I'm looking over there, I'm looking at YouTube. If I'm looking here, I'm looking at Facebook in terms of questions. I also do a drop-in Facebook meeting, which we did Friday night. That's always if I have time, if I'm not doing another coaching session or something like that. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you that this is all in your head. I don't want anybody telling you that you're damaged goods. I don't want anybody suggesting that there's no hope. I don't want anybody telling you that you're going to live this way, because it's just simply not true. We know what IC is. IC is a grab bag diagnosis. What that means is that you have symptoms of frequency, urgency, pressure, pain, but the doctor doesn't necessarily understand why. Normally, when you go to a physician the first time, the assumption is that you have UTI. They treat you with antibiotics, but you don't get better. You go back to the doctor. The doctor goes, well, let's do long-term antibiotics. They might do a urine culture. It might come back negative. But there's still an assumption here that we're dealing with a bladder issue because, hello, you're up all night. Hello, your bladder hurts. So, of course, you're thinking it's your bladder. But eventually, the long-term antibiotics don't work. And I'm not just speaking for women. I'm speaking for men, too. Absolutely for men. For those of you, for men who have been diagnosed with chronic prostatitis, you know what I mean. You've done the antibiotic dance. You've done the prostate medication dance. And ultimately, in the end, you haven't gotten better. Then at some point in time, somebody might suggest that you've got overactive bladder. Okay, I can take that. But you try those meds, they don't work. And eventually somebody says, well, we don't really know what's going on with you. Therefore, you must have interstitial cystitis, this incurable bladder disease. I hate to break it to you. Here's the diet. Here's Elmeron. I'll see you in 6 months. Now, that was 20 years ago, 10 years ago. We're not there anymore. Now we very clearly understand that IC is a pelvic pain syndrome. That for many of us, if not most of us, yes, we have bladder symptoms, but our bladders look good. It's very confusing. I mean, like, I can remember when I was younger, especially when I had vulvodynia, which kind of goes with this. I would be laying on the table, the doctor examining me. I'd be crying in pain. He'd go, you look normal. And you're like going, what the hell? Wait, I'm dying here. Please help me understand why I have so much pain. And now we know why. Now we know that there are very distinct subgroups. That for some of you, IC begins in childhood, perhaps after a traumatic injury or a history of abuse, or if you were in an accident, or if you fell and broke your tailbone, if you jammed your crotch on the bar of your bicycle. For others, IC begins after chemotherapy, because the bladder, like any other part of the body, can be injured. And generally, the way it's injured is with some sort of chemical exposure. For some of you, IC begins after having a baby. While for others, IC begins when you start birth control, or when you go through perimenopause or menopause. Are we all the same? No, hell no, we are not all the same. And that's the biggest thing that's happened. It's the biggest thing, that progressive thing that's happened in the last 5 to 10 years is we are done with the incurable bladder disease dance. The only people that have bladder disease, according to the American Urology Association, are patients who have UTI and or patients who might have Hunner's lesions, although that can be qualified too. For the rest of us, it's a chronic pelvic pain syndrome. Now, one of the mysteries is why do some of us, myself included, have bladder symptoms and bowel symptoms and vulvar symptoms and TMJ and fibromyalgia and other things like that. Now we know why bladder therapies don't work for those patients, because underneath it all, it's really not a separate bladder disease and a bowel disease and a vulva disease and a bone disease. It is a central nervous system disorder. So therapeutically now we're focusing on calming the central nervous system. So with the brand new AUA guidelines that came out a couple of weeks ago, and I just started last night, this massive, like for the first time in 20 years, I have to rewrite my entire website. It's crazy. I got to change everything. I got to change all the links. I got to change everything now that we have these new guidelines. But it is very, very exciting. Also, I will tell you, I attended an international IC meeting of the International IC Support Groups early Friday morning. I'd get up at 6 in the morning to start at 7. And what I love, finally, I mean, we dreamed of this 20 years ago. We tried to do this 20 years ago. We tried to have an international IC collegium, for lack of a better term, where every support group had an equal seat at the table. Imagine a giant round table of patient groups from around the world who could come together and discuss our issues. But politics got in the way back then. 20 years ago, there was a massive amount of fighting. So it was simply impossible for the IC support groups to sit down together. Groups in Europe were feuding with each other. Groups in America were feuding with each other. There were just feuds everywhere. Well, that's all done. That generation is, for the most part, gone. Today, we now have, led by some Europeans, this fabulous international roundtable. We had a fantastic meeting. We are representing very diverse patient populations, but we have some commonalities, and that is, how do we educate patients? How do we get them the right treatments? How can they afford those treatments, et cetera, et cetera? So I'm going to chair the patient education committee, and we're going to see what we can do to kind of improve care around the world. And so super, super excited. Thank you to Matilda and everybody else, Balaka, everybody else on that committee and panel. This is exactly what the IC world needed. I should introduce myself. I'm Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States at 29 years exactly. I was diagnosed with IC in June of 1992, and I started my first support group in 1993. So yes, I'm that old. So normally when I do these meetings, I do a little 30-minute blurb, and then I'll go ahead and take your questions. I do want to talk about something that's quite interesting, and that is, who do you think should treat IC? I had a discussion with a urologist, a female urologist in the South who just retired. I had great discussions this week with doctors. Really, I mean, God, this is despite all the stress and trauma that's going on, IC people are coming together finally. So I had a fascinating discussion with this now retired urologist who was deeply concerned because there were no resources in her area now for IC patients. And so we're going to work on that. And one of the things that she said to me, she said, you know, Jill, I don't know if you really understand, but there are fewer urologists now. It's actually hard to find urologists. We know. We know this, right? You all know this. That it's hard to find a urologist who is not only interested in IC, but is trained correctly. But what I didn't really understand is that the population of urologists seems to be on a decline right now. I think medicine as a whole is going through very, very dark times. We've seen a lot of doctors just quit. They can't take the abuse anymore. And just as people are acting out on planes and being completely disgraceful, people are acting out in hospitals and going into hospitals and hurting people. And it is no wonder that many physicians are walking away, and they have every right to walk away when they're treated and scared for their lives. Throw in working with COVID for 3 years and being afraid for their lives there, it's a problem. And every single one of us owe it to our care providers to thank them. Thank them. Please treat them nicely. Thank them for being there. Thank them for trying to help you. We have got to do everything we can to make this better and easier for the next generation of IC patients. We do. So when you go, I believe in gifts. Whenever I went to my urologist, back when I had a urologist, I brought things that I thought would be useful, and he was very grateful. Not food. I'm not talking about stuff like that, but just, new articles, books. I've given a lot of books away. I bought a lot of books for doctors just because I think that they're really useful. So please treat your doctors kindly. So with this decline now of urologists, where should patients go for therapy? Should they go to a gynecologist? Well, the American Urology Association guidelines make the case that perhaps IC should be treated by primary care providers. Because think about it. One of the problems with going to a specialist is that they have tunnel vision. They play in their sandbox, which is the urinary tract, right? A urologist focuses on the urinary tract. A urogynecologist is going to focus on the reproductive tract and the urinary tract. Gastroenterologist is going to focus on the bowel. They don't focus on muscles so much. They don't focus on nerves so much. They don't focus on bones so much. And we now know that muscles, nerves, and bones play a role in this. And how many of us, and the other, I think, the thing that's really tragic are the number of patients who have endured completely unnecessary surgical procedures. Like, for example, Cindy, I agree, we'll get that. The number of women who have had completely unnecessary hysterectomies because the gynecologist thought the pain was coming from their uterus, as compared to the men who have had completely unnecessary prostatectomies or TURP procedures only to discover after the fact that perhaps it was muscles. So specialists, yes, the advantage of a urologist is that they have a strong interest in the field of urology, working with the bladder and all this sort of stuff, and they're going to be more trained because they're certified. They have extra training in this area, and they go to conferences, and they tend to have a passion for this. But they can also have tunnel vision, such as those older urologists who don't believe IC is real. A primary care provider, on the other hand, they work with everything. They absolutely work with everything. They work with sprained ankles. They work with bones. They work with muscles. They work with organs. They work with bladder infections. They work with hemorrhoids. They're perhaps a little bit more open-minded in terms of trying to treat and understand pelvic pain conditions. But as Cindy said here, the problem is that they have no training. And the odds of them getting training in pelvic pain is slim. You're lucky. How often do primary care providers go to conferences? Oh, maybe, I don't know. Honestly, I don't know. How many urologists go to urology training? Maybe one conference a year, one conference every other year. And when they go, are they going to take the IC class? Who knows? So this is why you have to be extremely educated here, because you are the captain of your ship. You pay them, they don't pay you. You are the boss. You have to direct your care. And so in a way, we've gone forwards. They're acknowledging groups and subtypes. Hallelujah. But we've gone kind of backwards now in a way too, because now the AUA is suggesting that your doctor is going to have the time to go over every single treatment, every single risk, every single benefit in a tiny, tiny little window of an appointment. And so with time constraints, with doctor training and everything, we don't have a choice. We have to be educated. You have to be, and you can't walk into the doctor's office and start crying and say, oh, it hurts, please make it go away. You have to walk into the doctor's office and say, I get up 4 times a night. I have pain when I try to empty my bladder, when my bladder gets full. I get pain that shoots down my leg randomly. I get this, I get that. You have to be able to walk into your doctor's office prepared to discuss your symptoms. And I always say, don't say I see, especially if you're getting a second opinion. For God's sake, don't say I see. I see is the wrong word anyway. We're not going to be using interstitial cystitis much longer. I'm going to have to change the name of the IC network soon, because the Europeans are now not using the term interstitial cystitis at all. They're using bladder pain syndrome, right? But don't walk in and say, hey, I've got an IC. Walk in and discuss your symptoms. So, doc, here's the issue. I have to use the restroom every 30 minutes. I have pain when I try to have sex. I'm afraid to have sex. It's going to hurt so bad. I'm down to eating 4 to 5 foods. Can you please help me understand the structure that's driving this symptom? Because we need a fresh set of eyes. We need a fresh set of eyes at your body, and not just at your bladder, but we got to look at freaking everything. Could you have a fibroid tumor pushing on your bladder? Could you have endometriosis? Could you have a ruptured disc in your back? Could you have a broken tailbone that's healed out of position? Could you have a bad ankle? Could you have a bad knee? The pelvis is at the center of the body. It is carries the weight of your torso. It absorbs the stresses from when you walk. There are many, many things that can trigger pelvic pain and bladder pain. But the bladder, understand, is often the victim of another dysfunction in the pelvis. So let me give you an idea. This is interesting because back from my earliest days of IC, there were patients who said, I feel like I'm carrying a bowling ball around in my pelvis. And just pressure, but heaviness. And as the day goes on, it gets heavier and heavier until finally you feel like you're walking around holding up a bowling ball. And by the end of the day, it might even be uncomfortable to walk. Well, now we know exactly what that is. I mean, we now know that that's pelvic congestion syndrome, also known as varicose veins in your pelvis. And so what happens is that these veins are no longer pushing. As the day goes on, they aren't pushing the blood along well, and the blood starts to accumulate, and it gets fuller and fuller and heavier and heavier and heavier. And then at night, when you lay down, the blood has an opportunity to go back where it goes back into the rest of the circulatory system. It's not collecting in your pelvis until you get up again in the morning, and then slowly but steadily it starts to fill up and get bigger and bigger. So if you have that sensation of heaviness, feeling like there's a bowling ball, that's the question you're going to ask your doctors. Why does it feel so heavy? Could this be pelvic congestion syndrome? Because you will have walked in educated and informed. And if the doctor goes, possibly, you're going to say, all right, can I get a referral to an interventional radiologist, who's a radiologist who diagnoses that? And the great news is that's completely treatable. Completely treatable. Here, hold on a sec. Let me break out this. Let me pop out my chat here so I can see it more easily. Why do I have a security alert? All right, hold on. All right. Hi, Anne. Hello, Audrey. Hi, Sylvianne. Hello, Lisa. I hope you're playing tennis. Hello, Deborah. Audrey says, what what happens if it happened after a UTI? Well, there are just a couple of things that we have to ponder with that. Question number one is the infection gone? There are some bacteria that are remarkably adept at defeating antibiotics, hiding. They don't hide. Well, no, they do hide from antibiotics. Like E. coli, for example, if it faces a threat, this is according to Dr. Scott Holtgren, who runs a E. coli lab. You can just Google his name. I just sent it to somebody. He has on video. His videos are absolutely fascinating of what happens during infection. And E. coli, when it senses a threat, it does two things. One of the things that it does is it changes its shape. Normally, it's like oblong, like this, right? Right? Well, it's probably narrow like this, right? Without the fingers. So what E. coli does is it becomes this. It becomes a noodle. And as it changes shape, the white blood cells can't recognize it and kill it. So that's one thing that can happen with E. coli. Another thing that can happen with E. coli is it plants seeds in the face of a severe threat like antibiotics. It commits suicide. What it does, and I don't know how it does it, but it cuts off little copies of either DNA or RNA, wraps it in a little cell membrane deep in the tissue, where it sits there. It's passive. Nothing happens. It's not living. It's just a little piece of E. coli DNA. And then our own healing process turns it back on, and it creates a new infection. So now that was, I know, I got to be totally honest. I probably haven't read Dr. Holgren's research in the last couple of years. We've been too busy. So there might be new changes in that, but that was the last thing that I read. And so so infection is challenging. This is why we also do something called next generation DNA testing. We now know that a typical urine culture is going to miss over 90% of the potential bacteria that are in your urine. Now, understand there's good bacteria in your urine. Urine is not sterile. Your urinary tract is filled with really good beneficial bacteria. But it also has the potential to have an overgrowth of pathological bacteria, damaging bacteria. And so rather than using urine cultures, we do next generation DNA urine tests. That's the same technique that identifies COVID infections. They can identify viral DNA. They can identify fungal DNA. They can identify bacterial DNA. And that will give us a much better idea of what's happening in your bladder. So concept number one is you still could have infection. Concept number two, though, is that the infection could be gone. I mean, it's dead. The problem is that the damage left behind the infection can take weeks and weeks and weeks to heal. So let me hold up this here for a moment. So this is one of the old Elmeron patient education tools. And so I want you to know that your bladder basically has a couple of distinct layers. This upper blue layer, but it's not really blue, is your GAG layer, your glycosaminoglycan layer. The purpose of the GAG layer is to protect the tissue. And then underneath that are your urothelial cells. These are the largest cells in the human body. They are connected with something called tight junctions. So that nothing can get through them, and you can see about 4 or 5 layers of cells, and then underneath that we've got nerves and blood vessels and other things going on. So let's just say, for example, that you are postmenopausal, and because you're postmenopausal, you no longer have that nice thick coating of mucus, because this GAG layer is estrogen dependent. It loves estrogen. So as you get older, if you're on birth control, you lose some of this GAG layer. So now what we can see is bacteria and other irritants in your urine now reach the cells. And so unfortunately what happens now is that the bacteria infect the top cell. So let's just say the bacteria has infected this cell. It turns it into a bacteria factory. It then ruptures, releases the next generation of bacteria who then infect this cell. Another bacteria factory, release it, infect this cell, and this cell, and this cell, and this cell, and this cell. And you basically end up with the equivalent of tunnels. And the tunnels can go quite deep. The tunnels can actually get down to where your nerves are and create a lot more issues. So if you've had a very, very severe infection, there's going to be a lot of tissue damage, and it's going to take weeks. It takes 2 weeks for one of these cells to be replaced. 2 weeks. Nothing happens overnight. Healing takes time. And God forbid you be a diet soda drinker and you're here, you've got this wounded, injured bladder, and you're pouring acid in the tunnels. Yeah, it's not going to heal. Your job is to create an environment to support healing. So tissue injury after infection is real. And then, of course, the other challenge here is that when your bladder is screaming in pain from a bad infection, your muscles get tight to protect you. That's called the guarding reflex. So now we've got another issue. We've got muscles so tight it's restricting blood flow. Angie says she takes her books with me to primary care. Yeah. Okay, hold on. Let me go back here. Oh, wait, here. Hold on. Sylviane says, hi, Sylviane. Oh, I already said hi. Well, hi again. I have a strange question. Is it normal for people with IC to always have a very small amount of pee at a time? It seems like the bladder is very small and not normal. No, for some people it can be very, very small, especially if you have Hunner's lesions. If the bladder wall is injured over time, think about the bladder for a moment. It's a balloon, for lack of a better term. It's basically quite small. Where's my model? It's quite small to start with. Let's just pretend it's this big. But as it fills with urine, it stretches, right? It stretches. And then when you empty your bladder, it contracts. And then it fills again. I mean, it's really kind of miraculous the way the bladder works. We call this basic bladder studies in terms of trying to understand the mechanisms by which that stretching happens, et cetera, et cetera. But for a bladder that's really, really injured, it loses its stretch, and so it stays quite small. And it might even shrink and get a little bit smaller. Some people with really severe bladder disease might have a bladder the size of a walnut. And so for those patients, bladder capacity is obviously very, very small. But the other thing, Sylviane, that we have to really think about is muscle tension. Your bladder might be full, but the question is, are your muscles relaxing enough to empty your bladder? Right? That's the other really thing is if your muscles are super tight around your urethra, around your rectum, it's going to be hard to have a bowel movement. It's going to be hard to release urine. And that's how I always know when my muscles are getting tweaked. I can absolutely tell by the way I'm peeing. If I can go in and pee like a horse, I'm good. If I'm going in and I'm stopping, rocking back and forth, standing up and down, no, that means my muscles are tweaky. And I've got to get in and do my muscle work. Cindy said my primary doesn't know anything about it. Exactly, that's the problem. I think it's unrealistic for the American Urology Association to think that primary care providers can take over the burden of care for the typical pelvic pain patient without really intensive training. I mean, we already know what happens. We already know that many, many patients are told that it's all in their head or just given antibiotics. And it takes there's a lot of complexity in pelvic pain, and we have to understand and study and evaluate many different things that can play a role in your symptoms, from the health of your bladder to the health of your muscles to the health of surrounding tissues, the health of nerves, the presence of UTI, the presence of fungus or virus, the presence of cancer. If you're a smoker, that's one thing the new AUA guidelines are really crystal clear on. If you have exposure to tobacco, whether through smoking or secondhand smoke, I mean, they want every single new patient to have their urine studied for blood, because if there's a sizable amount of even microscopic blood in your urine, they want to, and you have a history of tobacco exposure, even as a child, we now know research shows that if you have children in your home and they're exposed to your secondhand smoke, they're going to have the symptoms of IC, frequency, urgency, maybe some pressure, maybe some pain. So they want anybody with a history of tobacco exposure to get a proper workup for bladder cancer, because smoking is the #1 cause of bladder cancer. So that's fairly new too. That's kind of a new, I mean, it's always been in there, but they're being a little bit more direct about it. Hello, Deborah. Let's see here. Oh, wait, hold on. I'm looking at the wrong window. Got to get my desktop working. And you guys over on YouTube, hey, are you, can you guys tell me, are you hearing me okay? Is everything okay over on YouTube? Because you're being a little bit quiet over there. It makes me wonder. Makes me wonder what's going on over in YouTube land. Lori says, true, a primary would be great, but that's going to take a lot of education. You're right. Hello, Carolyn from England. Nice to see. It's very, very nice to see you, hon. Lori says, what about Hyprex? My urologist prescribed it for me, but I do not have infections that show up on normal lab testing. Well, I mean, normal lab testing. So I would want to do a next generation test just out of curiosity to see if there's something there. Let me refresh my memory on Hyprex here real quick, because you got Hyprex. There's lots of other things going on. Ooh, I want to leave that there. I want to talk about here. Let me leave that screen open because I want to talk about that. Isn't it methenamine? Yeah, it's methenamine. It's used to treat bladder and kidney infections. Is a urinary anti-infective medication used to treat and prevent UTI. Hyprex is available in generic form. And let's see, can Hyprex long-term use? Let's just see, can you take it long-term? Taking doses of 8 grams per day more than 3 weeks can cause bladder irritation, frequent and painful urination, protein in the urine, and bloody urine. It's important that you take methenamine, also known as Hyprex, exactly as prescribed. That's what was tweaking there. Now, during our meeting on Friday, we had a patient who had a rare and very difficult to treat infection called Proteus mirabilis. And so we were doing a little bit of research for her online with Proteus. Proteus has feli, like lots of little, like fuzzy arms going around the bacteria that allow it to move easily. Think about a caterpillar. You know, caterpillars always have, well, in addition to their legs, always have lots of little hairs that's sticking out. Well, for bacteria, those little hairs help with movement. Proteus is an exceptionally difficult bladder infection to treat, and it's known for swarming. It is let's see. It's common in UTI, pneumonia, intra-abdominal infections, skin and soft tissue infections, biliary tract infections. I mean, it's fascinating. Fascinating that we have, you know, our bodies are its own little world, and we're just learning about our biome, and we're learning about all the different influences that happen. And so you think about a swarm of bees flying through your neighborhood. Well, you can have a little swarm of Proteus if you're unfortunate enough to have Proteus, which appears to be more of a nosocomial infection. If I remember correctly, you get it in a hospital setting. So anyway, Angie says, that's what I said the other day. We need to raise doctor awareness, especially with the new changes. Yeah, we'll be doing that with IC Awareness Month this year for sure. I have to start writing the IC Awareness Month materials probably next week, just to try to get that moving along. And so clearly what we're going to be talking about are kind of the new guidelines and the new subtypes. Oh, thank you. Somebody just gave me stars. Thank you so much. I really, really appreciate that. I can't see it yet, but when I see it, I will acknowledge you by name. Deb says, mine doesn't, but prescribes my medicine that my urogynecologist originally prescribed for me. Cool. Yeah, my primary care provider does too, because my urologist retired, my gynecologist retired, and I've gone through 3 primary care providers in 2 years because they keep retiring at Kaiser, and you just keep getting reassigned. I have to make my case every time. Can you please redo my Flexeril prescription? I take it for pelvic floor dysfunction. Yeah. Cindy said, will I have this new name on the website? Yeah, we're going to have to decide what the right name is. I mean, we could change the IC network to the IC and Chronic Pelvic Pain Network. We could change it to, or what I can do is we can just start a new website dedicated to chronic pelvic pain, because I already have all the domain names. So I can do that. Just haven't had the time to do it. And so we can have a central chronic pelvic pain website, and then the IC portion will point to the IC network. The vulvar portion will point to that one. The testicle pain will point to that one. I've got all of those domain names, and I'm going to build all of them out. They're all going to get built out this fall. I am in writing mode, my friend. Whoo! I'm in writing and video mode. And now that I don't have a headache anymore, you know, it's like, oh, I'm a new woman. Betsa says, I'm afraid to use estrogen for the reason of the side effects. I have a flare of pelvic pain so bad. Maybe that's the cause of my pelvic pain because I'm fighting the bladder infection. Well, Betsa, I don't quite understand your question. So, without estrogen, you're more vulnerable to infection. You know, if you're on birth control, if you're perimenopausal, menopausal, postmenopausal, you have to remember that you don't have as thick of a bladder coating anymore. This nice thick coating is what protects you from infection. It's what protects the tissue from irritants in your urine. So what happens is you lose estrogen is you start losing this nice thick protective coating. And if you've had 2 infections in 6 months, 3 infections in a year, you are in the recurring UTI category, and you're no longer a simple UTI. You are considered and classified as a complex UTI. And generally, a major part of that treatment is to try to improve the health of your skin. And the way that they do that is with topical estrogen. So now, of course, some women, the problem is that for some women, when you start using estrogen, it's hot. I mean, it can be quite hot. And you're like, oh, hell no, I'm not going to use this. This hurts. Well, the reason it's hot is because your skin is dry. That's normal. The hotter it is, the drier your skin. But your skin immediately starts using that estrogen to produce mucus. So that heat every single time gets less and less and less and less as your skin gets more and more normal. It took me about 2 weeks to get there, 10 days to 2 weeks. And then instead of it being hot, it was like a warm puff of air. But some women get really afraid of that. And they're like, I'm not going to take that estrogen, that hurt. Well, the problem is that you're just going to get drier and drier and drier. And then when you're going to try estrogen again, it's going to hurt even more, you know? So that's a problem. Hold on a sec. Are you guys okay on YouTube? Can somebody please? All right, YouTube, I'm looking at you right there because your camera is right there. My Facebook camera is right there. YouTube, can y'all say hi or something in there, because I'm not seeing anything. And I know you're there because I can see you. All right. Angela says, thoughts on estrogen testosterone compound cream to put on the urethra to help with urethral pain? I think it's solid. I had urethral pain. That's when my estrogen atrophy occurred. It manifested as urethral pain, but they didn't give me a estrogen testosterone cream. They just gave me an estrogen cream, and that's what keeps it under control. It's become more of a trend now for doctors to combine estrogen and testosterone. Lisa, thank you so much for the 100 stars. Thank you, thank you, thank you. Lisa says, I had a microgen PCR urine test done with a naturopath. It showed small amounts of E. coli. Thank you, Donna. She thinks it's an embedded infection. How does this test know it's embedded versus normal bacteria living in harmony with good bacteria? She suggested long-term daily antibiotics for up to 6 months, or she preferred herbal botanical teas to get rid of it. I told her I would like to ask my urologist what he thinks. Well, Lisa, you have just perfectly described the challenge that we all face because we're still learning about the urinary biome. I will tell you, so after I had my hysterectomy 5 years ago, my urine was very cloudy, and it was cloudy for about a year. And I was just like baffled. Like, why is my urine? I mean, I wasn't necessarily having a lot of symptoms, but it didn't look normal. It was cloudy. And so I had a next generation DNA test because I actually thought that maybe it was a fungal infection. But what my test revealed was like 2 to 3% E. coli. And it was so little that I and my my gynecologist at the time, this was my gynecologist that ordered it, we decided that we were not going to use antibiotics and destroy my biome for 2 to 3%, because I had no symptoms. And so then, which is ironic because I've now been on antibiotics 3 times this year, and I'm on them right now for the infection where this root canal was. Anyway, I interviewed the founder of Microgen a couple of years ago, and I posted that directly to him. It's like, okay, so a patient has a little bit of E. coli, but they have no symptoms. What do you do? What's the strategy? And he said, you don't treat. You have to have abnormal results and active symptoms to justify the use of the antibiotics. That was his perspective, and that was my personal gynecologist perspective, that we don't want to just arbitrarily take antibiotics knowing the tremendous damage that it can do, as well as create an environment for yeast to grow, right? So I think the fact that you have no symptoms should be your focus here. If you were symptomatic, I'd say, yeah, man, antibiotics, but you have no symptoms. So why do it? Why damage the rest of your body and do it? I mean, obviously, I'm not a doctor. I can't give you medical advice. I think it's important you have that discussion with your doctor like I had with my doctor. Judy says, I was told I have a thin bladder lining and you're taking estrogen. Exactly. That's what happens as we get older. 60 is the new 40. My birthday is in 2 weeks. My new age is 42. Which means obviously I'm older than 42, but yeah. I took the Facebook age test. I aged out at 28 on Facebook. So when I'm gaming and stuff like that, and see people say, how old are you? I go, well, I took the Facebook age test and it said I was 28. So that's my story and I'm sticking to it. They would be stunned to find out they were playing with an older woman. It's funny. Debbie's taking Vagifem tabs every 4 to 5 days. Run it under water to soften it up a bit. A lifesaver. Excellent. Cindy said, I was given Reverie suppository for my vagina. I told my doctor that it makes my vagina itchy. She said to keep using this. I can't seem to go back. What would you recommend? Hold on. Let's just look at that real quick. Reverie. Revaree. It's a drug-free, hormone-free, formulated with naturally derived hyaluronic acid that safely hydrates and renews vaginal tissue for lasting relief. 86% of Revere users experience an improvement in vaginal dryness in 45 days. Your key to renewed moisture and increased comfort during intimacy. Well, so it's not going to fix the underlying problem. The underlying problem is dryness from estrogen atrophy. When you give that skin estrogen, it produces mucus. What you're doing is you're putting in a fake mucus. You know, you're putting in a temporary mucus, a hyaluronic acid that's going to go away. And so you're going to chase that dryness for years if you do it that way, and you're going to have to use it a couple of times a day. Whereas if you're just using a little bit of topical estrogen, your skin will become more naturally moist. Anyway, thank you, Lori. Lori said I looked fabulous today. You know what? I had a good day because I woke up early and I gardened for 2 hours. I went to the nursery last night. I got a whole bunch of new dahlias. Took out my spring plants, put in my summer plants, and I got to spend the day exactly the way I needed it, just to kind of chill out in my front yard, gardening and planting. I want to try to be a little bit more regimented. I want to have a schedule. You know, I think that we all end up kind of fighting fires in our lives. You know, like something happens here and we got to run and tend it. Something happens there and we got to run and tend it. Something happens there. And before you know it, it's the end of the day and you haven't accomplished what you'd like to accomplish. And I'm tired of like going from crisis to crisis to crisis. I want a schedule, a good schedule. So I'd like to get up in the morning, do my my physical therapy and my pelvic floor work and my jaw work, because we found I have arthritis in my jaw. That's why my TMJ is so bad. I would like to take at least one class a day in something I need to learn for my work. And so for me right now, it's graphics. I'm not producing graphics that I like for the IC network. I would like to spend an hour a day reading about IC. I would like to spend 3 or 4 hours a day working with patients on the phone. And then I need my time to rest and recover, you know? And I'm desperate to go back to the gym, but I won't do it. I won't go back I'm still paying every month. I paid every month for 2.5 years and I haven't gone, but they massively reduced it. I'm only paying $10 a month to save my membership. Because new members have to pay like $75 a month, and I'll only have to pay $30 a month when I go back. All right. Rebecca says, I have estrogen atrophy. They only prescribe vaginal cream. I feel like it's not enough. You still have pain. Rebecca, where is the pain? Is the pain in your vagina, on your vulva, in your urethra? Tell me where your pain is. Gabby says, will my doctor be able to determine if I need estrogen? Absolutely. They'll just look at your skin. Dry skin presents in a very specific way. And it can create, you're not going to see it. You might feel the dryness, but doctors can see that easily. It gets thinner. Sally over on YouTube says, I've consistently had blood in my urine for the last couple of years. Can Hunner's lesions cause this? Yes, they can. Sally, is it visible blood that you can see? Are you peeing pink? Are you passing blood clots, or is it microscopic? Donna, you got a total gym and you love it? I gotta look at that. I'm about ready to do that. Betsa says, I have very bad pelvic pain flare, side of my thighs. Is it a reason when you, okay, hold, Betsa, wait. I have a very bad pelvic pain flare. What's on the side of your thighs? Are you feeling pain on the side of your thighs? If you've hurt your leg, if you stressed your leg, you're gonna those muscles from your thighs go right up into your pelvic floor and will certainly tighten your pelvic floor. So what happened to your legs? Jasmine says, I'm 25 and I've already had Hunner's lesions cauterized once. It is getting bad again, and I'm curious if anyone with lesions have tried multiple treatments and found one help more than the other. I'm frustrated being young and unable. Okay, so Jasmine, let's talk about this for a moment. Number one, Hunner's lesions respond beautifully to therapy. The research is overwhelming. It's absolutely recommended in the AUA guidelines that if you have open Hunner's lesions, active Hunner's lesions, that they treat it with either steroid injection or fulguration. They could try some hyperbaric oxygen therapy. Hunner's lesions are not going to respond to DMSO, rescue installations, stuff like that. Elmeron, we just don't have any data that supports that. What lesions respond to lesion-specific therapy. And so the question then, the real question is, what is a lesion? What causes a lesion in the first place? And the European IC researchers made a remarkable discovery 5, 6, 7 years ago when they found a virus in the urine of patients with lesions. It's a virus called the polyoma virus. Polyoma is a virus that we all have. It's not a sexually transmitted disease. You don't need to worry about that. It's a normal part of the human biome. And it gets turned on in people who are immune compromised. So we have a couple of studies from Europe. And, what's interesting is, so when all these came out, and, I was reading these studies and we were talking about them in our meetings, we were just waiting for the Americans to make a response to it because this is fairly big. And for several years, like 4 or 5 years, our own National Institutes of Health were remarkably quiet about it. And I'm like, guys, seriously, if it's a virus, can't we use an antiviral? Well, what I didn't know is that they were doing their own viral studies. They have urine samples. They have a cluster of patients who have given urine samples over the years to them that they study. And they went back and they looked at those samples, and they did find polyoma virus in a very small subset of patients, but it was there. So that's very interesting. So also Epstein-Barr, the Epstein-Barr virus is something else that we want to possibly consider in relationship to damaging the bladder wall. Polyoma virus has absolutely been linked to bleeding lesions in the bladder. It's called hemorrhagic cystitis. And so it's commonly seen in patients who, for example, are on anti-rejection drugs for kidney transplant, or patients who are immune compromised. The virus gets turned on and it causes an infection in the bladder wall. So that's concept number one. But there's a far more interesting case that happened a year ago. They published the paper of a woman with very severe Hunner's lesions and very severe prolapse. And so when they went in to surgically repair her prolapse, because when you have a prolapse, organs are falling out of your body. That's a bad thing. We have to get the organs back up in their proper position. So they decided that they needed to try to repair that. And they made a remarkable discovery. When they opened her up to do that, the back of her uterus was facing front and the front of her uterus was facing backwards. Normally your uterus, this is a good kind of example, your uterus is held in place by ligaments on both sides. One of her ligaments had broken. And so her uterus was swinging like this. And it was twisting. It might have even twisted a couple of times. I don't know. That's possible. We call that a strangulation injury. That has also happened in men. It's a very, very urgent issue because as that skin twists around, it blocks blood vessels and it's just devastating. So what was amazing about this patient is they went ahead and they reattached her uterus. They got everything in the proper position, and stunningly, her Hunner's lesions completely disappeared. she is considered a total and complete cure. So how is that possible? Well, the other theory behind a Hunner's lesion is that it's a nerve that is massively inflamed. Nerves that are inflamed release substances which are damaging to tissue. There's a substance called substance P. So if you've got a nerve that's firing, the area around that nerve is probably going to turn red and get redder and redder the more irritated that nerve becomes, because that nerve is releasing toxic irritants. So it may be that because her uterus was swinging like that, the nerves were getting traumatized and they were causing that damage. And once they corrected that, the nerves were no longer traumatized and her lesions healed. That is another theory. These are theory. This is one of the great mysteries as why do Hunner's lesions occur. We have two theories right now. Number one, viral infection. Number two, neuroinflammation. So I would, if I were in your situation, I think I would want a viral screen, which they can do as a blood test, just out of curiosity, just to see if you have any active viral infection. And then also I would want a really good gynecological exam just to make sure everything's in its proper position. I would also want to know if you have any areas of numbness, pins and needles, any other weird, funky symptoms. Like, do you have PGAD, persistent genital arousal disorder, where you feel aroused randomly out of the blue and it hurts? It's not fun. There's nothing fun about it, but it's very, very confusing. It's also very, very embarrassing. And so a lot of patients don't talk about it, but it's very common. Do you ever have pain shooting down a leg? Do you have tingling when you sit down? Do you ever feel a fluttering sensation like you're sitting on a cell phone on vibrate? All of those would help us understand if nerves are involved in your case. You're not alone, my dear. You're so not alone. You are not alone. Lori says, I would love to take a cycle class again, but forget it with my pelvic floor. Lori, over on the IC Network website, we just about a month ago published an article on how to bike, suggestions on how to bike safely, even with pelvic floor issues. A lot of it has to do with the seat that you have. Heather says, side of the thighs is usually connective tissue, and I struggle with that along with my spastic pelvic floor. Is it the inside of your thighs or the outside of your thighs? I don't think I've ever, I don't think I've ever had persisting pain on the inside of my thighs. But I do get pain on the outside of my left hip that sometimes goes down my leg. Angie says, does anybody else have very painful mornings? Morning is the worst time for me. Really? So that's interesting, Angie. One of the things that happens is our urine concentrates overnight and becomes super irritated. And so when you get up at, let's just say you have to get up at 6, let's just say you've gone to bed at 11, you've gotten up at 2, you've gotten up at 4, you've gotten up at 6. By 6 o'clock, you want to definitely drink a bit of water. Let's start flushing that bladder out a little bit. I have to wonder though, is the way you're sleeping part of the problem? Are you sleeping on your left side or your right side? Is that tweaking something? Is it, when you say pain, what's the pain like in the morning? Is it bladder pain? Is it pelvic pain? Is it on the left side, on the right side? Cindy said, I have dry skin with bumps that make it itchy. My dermatologist thought I should get an injection for my neck, that I do have bulging discs. My doctor stated this will help. Well, guess what? My muscles have been throbbing back in the back and down the legs. My hands and feet feel asleep when I lay down. After the end of the week, my pelvis did hurt like a lot to pee. I spoke to my doctor, and she stated that it's inflammation, that it's in a flare. You're combining a lot of different things. You're combining your skin with a neck issue. With pain in your back and legs, and I would really, so I have ruptured discs in my back too, and I feel it in above my right knee. And normally I have to wear it. If I compress the area, it goes away. And they say it's a femoral nerve injury. Tricky, very tricky. Jasmine says mornings are worse for the most painful for her too. Angie says it's muscle pain, hips, back, pelvic pain. Oh, hi, Gloria. Hey, girl, long time no see. All right, so getting back to Sally on YouTube, she says her blood is microscopic. Well, I think that we, number one, with the new AUA guidelines, they want anybody with any blood in their urine to have a urine cytology test to rule out for cancer. I have always had microscopic blood in my urine. But I had this cytology test, and I'm not a smoker. I was never a smoker other than a couple of clove cigarettes in college. And so my risk is pretty low. But I will tell you quite honestly, in that first year, 1992 through 1993, I was in so much pain. I was convinced that I was dying of cancer. I completely and totally convinced. They told me IC. I went, I don't believe you. I think it's cancer. There's no way this bladder could hurt the way I'm hurting. I feel like I'm dying. Help me. And I demanded a laparoscopy. I demanded an exploratory surgery. And my gynecologist, Dr. Bennett, who I loved, he just retired a couple years ago. He kind of looked at me and he goes, really? And I went, oh, hell yeah. Open me up. I want you to look. Because I couldn't rest. I was obsessed with cancer. I totally thought that I was dying of cancer. And that makes sense because in some of the IC research, the IC pain's been rated equivalent to cancer pain. And so this is not little pain. This is characterized by being relentless, difficult to ignore. It absolutely pounds away at you. And so I had the laparoscopy in September of 1993. I still remember waking up in the recovery room, and he was right there. And he said, Jill, I found nothing. I found nothing. You do not have cancer. You are not dying. And I could rest. I mean, that allowed me to rest, right? That allowed me to finally go, okay. And that was important. That was important for my sanity at that time. And then ironically, again, when I had my last hydrodistension 5 years ago, perfectly normal bladder. There's nothing physically wrong with my bladder. And, the gynecologist was like, Jill, this proves once and for all, it was never your bladder. Never. It is your muscles and your nerves, which explains the pelvic floor tension and the IBS, I'm in total remission now. I don't have IC symptoms anymore. I don't have bowel symptoms anymore. Knock on wood. I don't have vulvar symptoms anymore. I'm only struggling with TMJ right now. And I never responded to bladder treatments. Now we know why, because that's not my subtype. My subtype's subtype 3, pelvic floor, subtype 5, central sensitization. Angie says she also has restless leg syndrome. I've never quite understood restless leg syndrome. I mean, I think we all have moments when we can't get comfortable. I'm not sleeping. I haven't slept in my bed in a year and a half because of my TMJ. I sleep in a recliner. Otherwise my jaw starts to dislocate. It's a challenge. I want to sleep on my bed, and I can only sleep on my left side. I can't sleep on my right side. And so I find sleeping in a recliner that I cross my legs sometimes. I don't have them straight out, and it feels really good. Cindy says, get an overnight guard for your TMJ. Honey, I've tried 3. They make my jaw dislocate more. They do. Guards don't work for me. I've had the front guards. I've had every type of guard you can have. And my jaw dislocates more. And now we know why. We know that I have arthritis in this jaw. And so this area, and sometimes you can see it. I'm dealing with, I was working with my physical therapist on this actually on Friday. My muscles from here to here are so freaking tight. And I have a trigger point I've had here for 25 years, like right here. I can feel it right now. It's like the size of an almond. And sometimes you can see it when I smile because this side doesn't open all the way because the muscles are so tight. And so we've been trying to, so we've done all the dental stuff. I do all the jaw exercises. It's not dislocating like it was a year ago. I mean, it's about 80% better, but I still can't sleep in my bed. And so now we've just started working here. We're working here. And what's interesting, what he said is you're thicker on this side than this side. You're tighter on this side than this side. And it's like, well, yeah, I was a professional tennis player and I'm right-handed. And so he's like, okay, now we know why you're bigger and tighter on this side than on this side. Being the aging athlete sucks. Sally says, I did a cystoscopy to check for cancer. It was negative. Excellent. I think my urologist may have given up on figuring out why my urine is bloody. Well, honey, did they do a hydrodistension with cystoscopy or did they do a cystoscopy? Because it's not just your bladder that can bleed, it's your kidneys that can bleed. I mean, like, let's look at this again. Microscopic blood, and the American Urology Association has guidelines on how to focus on what we call hematuria blood in your urine. But let me just try to explain this to you in a different way, okay? Because I think this will help. So again, we're looking at a 3-dimensional look at your bladder. You've got a bladder coating, you've got your urothelial cells, and underneath this, you've got nerves, and you can see these are blood vessels, okay? So let's just say you are of a certain age and you no longer have a nice thick coating. You now have a thinner coating. And so now irritants in your urine are getting exactly where they're not supposed to be. They're getting down here onto the urothelial cells. Now the urothelial cells, you don't think of your skin as being particularly communicative, but the urothelial cells are very active. They communicate. They communicate to your body, hey, invader, help, help, help. And this whole process begins. These cells tell your immune system something's where it's not supposed to be. The immune system gets notified. What does it do? It sends white blood cells to the area. It sends your army. Lymphocytes, white blood cells are our army. Their job is to kill invaders. So now we've got urine. So let's just say you drank a diet soda. So we've got formaldehyde from the diet soda now in here. There's no bacteria, it's just formaldehyde and formic acid. Now, of course, these cells cannot distinguish what the invader is. All it's just saying is, ouch, ouch, something's here, help me. So we got this army of white blood cells that swarm to the area. And they come up through these capillaries. So they're sitting here in the capillaries, but the problem is up here. So how does the white blood cell get from here to here? Well, the capillaries release them. The capillaries open. And when they open white blood cells, they also open, and when they open and release white blood cells, they also release red blood cells. And so this is why when you have a flare and you test your urine, you're positive for leukocytes. If you have a flare from drinking coffee, the odds are you're going to have leukocytes in your urine, and you're also probably going to have microscopic red blood cells in your urine, because that's just the way the bladder is built to defend itself. So I'm not worried about microscopic urine. Microscopic blood. I've had microscopic blood almost every single time that I've gone to the urologist. It's never been a big deal. The big deal is, number one, getting checked for cancer just out of curiosity. And then number two, making sure that we don't have anything else that could be bleeding. So if they've already done their due diligence and ruled it out, I think you can probably let that go. So he did not do a hydrodistension. Well, I showed a picture. So they would certainly have seen a big tumor in your bladder with a cystoscopy. Okay. I mean, I showed pictures of it a couple of weeks ago, a soft tumor. It's like a big floating mass of white cells. It turned out to be a cancer. I'm trying to remember what that slide was. It's a great slide. But then sometimes it's benign and sometimes it's not benign. It's malignant. So they would see that with a cysto, but unless he did what we call narrow band imaging with that cystoscopy, he would not have been able to identify Hunner's lesions. So you could potentially, I mean, listen, I don't like guessing. I like facts. If I'm in pain, I want somebody to look. You know, if I'm bleeding, I want somebody to look. That's just me. That's just me. I've learned over my lifetime not to wait. It's like I'll just worry about it for weeks and weeks and months and months. Now it's okay. If there's something weird, I want you to look and tell me if it's okay or not. And so if you have a negative cytology test, then I think you can rest. But if you were passing blood clots and you consistently had visible blood in your urine, or you know, your urine was pink instead of yellow, I would definitely be asking for a hydrodistension with cystoscopy. I personally would want somebody to look at my bladder if that was happening. So you've got to decide. I mean, and it depends upon what are your symptoms. Because if you're asymptomatic, then we could just be looking at a little bit of estrogen atrophy tweaking your bladder wall, causing that little bit of microscopic blood. And maybe it's not something you need to worry about. I know it's confusing. I know it is. Gabby says, do I still keep a low acid diet? You know, because I'm IC subtype 5 and I'm very, very sensitive, I'm very careful with my diet. I can eat tomatoes. I don't eat a lot, but I will put slices of tomatoes on sandwiches. I don't do tomato sauce often, more for my stomach than my bladder. I don't do typical sodas, just because I want to be healthy, and I can't stand carrying extra weight. I do not like having extra weight around my tummy, which I have right now. So I like to eat a really simple, fresh, healthy. I mean, like, I would be perfectly content having stir-fried vegetables, tofu, and rice every night. I could do that. I would never get bored on that. You know, because I had such severe IBS when I was younger, in my 20s, food was the enemy for me for a long time. And it's hard because, and it's not an enemy now, but I never enjoyed going out to eat with other people because I would often have IBS afterwards. And so I got very used to focusing on the foods that my body liked. And the foods that my body like are Ezekiel bread. That's a bread that I eat mostly. Ezekiel cereal. If I'm going to eat cereal, it's always going to be that. It's not going to be any other cereal. I don't eat any oatmeal. Oatmeal destroys my bowel. super sensitive to oatmeal, super sensitive to chocolate, and I try not to eat a lot of dairy. Mostly because I think I'm an animal lover now, and now I understand what happens to all those baby calves. So I do a lot of coconut milk now. I do coconut milk butter. Although I use butter if I'm making a regular butter if I'm making a cream sauce. Otherwise, I use coconut milk butter or olive oil butter. And I do sorbet if I'm doing something frozen, or I make myself a smoothie. I had Mexican food last night. I can do salsa. You know, my bladder's healthy now. And the reason why my bladder's healthy is because my muscles are healthy. I have good blood supply now. Back then, my muscles were locked down so tight, I was in total ischemia. That's why my bladder was so bad. But now, but bladder therapies never worked for me. Why? Because the underlying problem for me was never my bladder wall. The underlying problem for me was muscle. It was all muscle and nerve driven. It was never bladder wall driven. And I've shared that story that the day that I had bladder pain for the first time, by then I'd stopped playing tennis and I was doing like mini triathlons, and I love to swim. And I swam in a pool that made a massive mistake with their chemicals. And that night was the first night I had bladder pain. And so my first diagnosis was chemical cystitis. But I'm not sure if that's accurate now, even though the pool admitted it and many other people swimming had exactly the same problem. So clearly the toxic chemical was part of the problem. But that was when I was doing 100 flights of stairs a day. My workout was I would swim a mile or two, then I'd go do 100 flights of stairs, and then I'd row 5 miles. That was my workout, like every day for 10 years. So I also think that I could have tweaked my muscles really badly that day too. Angie says, restless leg syndrome feels terrible. It has spread to my arms now. I've had it for almost 35 years. Your legs just ache. All you want to do is rub them, but it doesn't help. I'm on medication for it, but it doesn't always work. I use a TENS, and I have this thing you wrap around your legs, and it squeezes them. Is it neurologic? Then are they saying that it's neurologically driven? The fact that you want to rub them, are you rubbing muscle or are you rubbing nerve? I mean, Angie, underneath it, what do you think is going on there? Gabby says, my anxiety has gone through the roof being new to IC. Can you talk a little bit about the effects of the nervous system on IC? Absolutely, Gabby. So anxiety is normal. Of course. Anybody diagnosed with something new, anybody in pain is going to be anxious. Yeah, because it's scary to be in pain and to not understand why you're in pain. And so it's very common for patients struggling with anything new to develop more anxiety. That's the very primitive part of your brain. We all have to remember that our bodies were built for life tens of thousands of years ago when we were running from saber-toothed tigers, right? And so there is a portion of your brain your nervous system called the sympathetic nervous system, and its job is to save your life. So if it perceives a threat, so if you open up your front door and you see a saber-toothed tiger across the street, your sympathetic nervous system immediately takes over everything. There's no cognition happening here. Your sympathetic nervous system pays attention to sensory information. What do you see? A tiger. What do you smell? A fire. What do you hear? A scream, right? It's monitoring your sensory information, and it puts you into fight or flight. Its job is to save your life. And normally then, let's just say the saber-tooth tiger has been caught. They have come out with their tranquilizers. They have tranquilized it, netted it, put it in a truck, and it's a long way away now. It'll never be back. Normally, once the threat is gone, then all that fight or flight turns off and your parasympathetic nervous system takes over. That's the part that's supposed to be active throughout the day. And what does it do? It relaxes your muscles. It reduces your heart rate. It reduces your blood pressure. We want to live on a daily basis with our parasympathetic nervous system taking with control over our brain, not our sympathetic nervous system. The challenge, though, and so that anxiety is a reflection of your fight or flight, because your brain is sensing the pain and it doesn't know what it is to any certain degree, and so you're in some fight or flight right now. And so it's very important that we get out of that fight or flight. There's nothing about IC that should scare you. I learned early on not to let myself get afraid when I have flares. It's a flare. It's a flare. It's okay. We know what to do during a flare. In mindfulness, we talk about this as the runaway train, that if every time you eat something and your bladder hurts, you panic, then you're working up your entire you're working up your entire nervous system. And so in mindfulness, their goal is to say, okay, well, so we know what it is, we know that it goes away, and we know you don't have to have the same emotional reaction to it every time. You don't have to have that runaway train of anxiety when you have this flare. Step off. We know what this flare is. This flare is that you ate or drank something you shouldn't have done. You've tweaked your bladder. It will calm down. If you do the right things, it will calm down. So what we don't want you to stay in heightened fight or flight, because that intensifies pain. It makes things worse. We have to try to calm that anxiety down a little bit. When I work with patients on the phone, I almost always end my conversations with, there's nothing about your case that scares me for you. You're not peeing blood clots. You're not demonstrating any sign of any severe bladder disease. I'm not worried about you. I'm not worried that you've got this fatal disease. What you have is injury or trauma. So let's take the fear out of this and let's focus on healing a little bit more. And sometimes just hearing somebody else say that to you, I'm not scared for you. This is a flare. It's okay. It happens. We've all done it. We've all been there. Does that make sense? Kind of, sort of? Jasmine said, is a viral infection test you were talking about the same test you used for testing UTI? I was getting tested at least monthly for about a year before finally getting sent to urology. Just want to be sure I asked for the correct test. And it was just standard. And was it just a standard gynecology exam you suggested? I take EpiPen and it really helps with my pain some days. My mom says your body eventually stops responding to it. Well, you do develop tolerance. Sometimes, every time you take a medication, your liver has a job, and that is to break it down. And so what happens is your liver gets really good at breaking it down. And so it can break it down very quickly, which is why you have to take more to get a beneficial effect. Okay, so with a viral infection, I've been told two things. I've been told that you can have a viral blood test that will help us see if you've got active virus, or they can look for virus in urine, but there's only one company in the United States that does that. I think it's called Aperiomics. Microgen, I don't believe, tests for viruses in urine, although you could call and ask them. Jeannie says, exactly, I feel like I have all this inflammation and it takes me a few to get moving in it and out of pain. I personally think it's all inflammation that builds up while I sleep. Well, it's possible. It's possible. But I would also be looking at how you're sleeping, where you're sleeping. We had that one patient who's been to our meetings a couple of times who they later discovered that she had massive black mold under the carpet in her house and in her bedroom. And everybody in the family was getting different types of illnesses. And for her, it was all bladder driven. And it turned out that her water heater had a leak and it soaked the entire carpet, the entire mat underneath the carpet. And there's black mold everywhere. And so they had to move out. They actually had to move out of the house. And um, I think they were, I don't remember what, they were either renting or whatever, but sometimes it can be something as simple as black mold. Denise says, every time I get a physical and check my urine, there's microscopic blood over 8 years now and I'm fine. Yeah. Rhonda says, can problems accrue from having a bladder lift? Yes. And will pelvic physical therapy be able to tell? Yes, honey. The fact that you had a bladder lift surgery means that your muscles were already compromised. Your muscles were already weak, probably from having children where muscles get stretched out. And so your bladder then loses the support that would keep it into place. So they will do a bladder lift to put it in the correct position. And the challenge with bladder lifts is getting the right tension. You always want a master surgeon to do surgeries like that because a lot of it is touch. How tight do we make it? And I remember working with one patient who had a bladder lift, and it was just very, very painful for her. It was way, 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 way too tight. And they had to go in and loosen it. And I think they had to loosen it 2 or 3 times before they got to the correct tension that was not painful, that still held her bladder in place. That was a very interesting case. And so basically the surgeon has to use their hands to try to find the right muscle tension. And sometimes they get it wrong. They can get it wrong. They can make it too tight, just like they can make it too loose. It's a finesse issue. So it's an experience issue. I wouldn't want a new young surgeon to do it, to be quite honest. And so having a good pelvic floor assessment would be good. Gloria said that she had breast cancer this year. You had surgery and it was successful with no chemo. Oh, honey, I'm so sorry. But you made it. You did it. You're over the worst. They got it all. Hallelujah, girl. Hallelujah. I'm so, so happy for you. I had a little, I mean, how many of us women have been called back? You get the dreaded phone call. We think we see something. We'd like you to come back for more testing and a sonogram. And this year, a couple months ago, I had spots in both breasts and I had to go back. And one of them was just an artifact, and the other one was a little tiny cyst, but the fear is real. Gloria, I'm so sorry, honey, that you went through that, but I'm so glad that you're over it. So your oncologist is saying no topical estrogen. Okay. If that's what the oncologist said, your life is precious, your life is important. So you're going to have to be doing other things that will try to keep that tissue fairly moist. Understand that bladder coating therapies might be good for you then, because as your skin gets thinner and thinner in your bladder, as your gag layer gets thinner, you're not going to have the estrogen to try to build it back up. So these are the patients who would really benefit from Elmeron, but of course we don't really, Elmeron is now linked to eye disease, so it's kind of not as popular as it used to be, obviously. But this is where a chondroitin-based supplement or a bladder installation would be reasonable, something that will give you a little bit of extra protection in your bladder. So Bladder Builder, Bladder Rest, Cysto Protect, Cysto Mend would be the top 3 chondroitin-based supplements. And that might give you some extra protection, right? Rhonda was right. Rhonda said he did it so tight. Exactly. It's very hard, but it's very hard for the surgeon. That's the problem. I mean, think about it. You have a finger here, holding this up, and they're just gently using their fingertip to try to assess the right tension. It's hard. It's hard. You okay?
Yeah.
Oh, come here, Dad. So my dad, you guys, come here. My dad was up early. We were both up early, and he hit. Oh, you have a little stain on your shirt. Look here.
22 shot.
Look at that. It's a blood blister. He hit his forehead on the corner of the shelf. Poor guy.
And this is the fourth time.
The fourth time, but it didn't break the skin. It's just underneath the skin. Dad. It's an adventure. Life is an adventure.
I'm going to venture downstairs.
Are you going to go downstairs and
I
work?
don't know. I'm trying to decide.
Okay. Oh, getting old. Imagine being 99 years old. He's going to be 100 in November. What goes through your head when you're 99 years old? He gets those, thoughtful moments. You can look in his eyes, and see it. All right. Lori says, can you give us a recipe for the ice drink? Sure. Let me get it here. Where did I put it? Ah, here it is. Okay. Dandy blend. You start with dandy blend. And guys, I just had a flash sale of it. I reduced it quite a bit just to try to give you guys a shot. And I think the flash sale is still going. I should have deactivated it, but it might still be activated in our store. You start with Dandy Blend Herbal Coffee. And so normally I do it. This is my Ninja juicing machine. So what I do is I fill this up with ice all the way to the top. I do a teaspoon of Dandy Blend, and then I fill it up to about this far with water. And then I'll do about an inch of coconut milk, and I'll just do maybe 2 tablespoons of vanilla coconut milk creamer to give it a little bit of flavor. You can blend it up, not blend it up. No acid, no caffeine. I can drink this I do drink this all day, every day. And it's just incredible. I'm a coffee lover. Coffee, my heart does not love coffee. I have no choice. I may never drink coffee again. The last time I did, I ended up in the hospital for hours with heart problems. And so this is my go-to. It's fabulous. And you know what? Hold on a sec. I got to go. Somebody did a stinker. I got to go open a window. Hold on. Woo! Yep, I was right. No, I was right. Open the windows. Turn the fan on when you use the bathroom. I really love these Mario Badescu facial sprays. They're very light, super easy for somebody with super sensitive skin. I can still remember the second office I had for the IC network was in a great building. And I was up on the second floor, and we had our own small bathroom. There were only like 5 tenants up there. It was really nice. Until one morning, I just about died. The smell was so bad from the bathroom. And it turned out one of the other tenants had Crohn's disease, and he was on massive medication. And we're talking knock you over. The smell was so bad. And so we call the landlord, please, is the vent working? This is awful. And we endured that for a year every time. And then they sold the building. New owner came in and came up and met us. And I said, I got to tell you, we got a huge problem with this bathroom. Could you please check the vent? It wasn't connected. The vent was not connected to it was, and the old landlord said it was. The new landlord confirmed no. They just put it in there to fake you guys out. It wasn't connected to anything. It's no wonder we were all dying. And of course, for the gentleman who had the Crohn's disease, I felt terrible for him too. It was awful. Angie says, rubbing calf muscles. I don't know what causes, not sure. Doctors know. I've never been told any reason. They just seem to blow it off. Cleveland Clinic says it can be genetic, and in addition to a genetic source, many medical problems are closely associated with restless leg syndrome, including low levels of iron, uremia, hypothyroidism, depression, fibromyalgia, Parkinson's, kidney, diabetes, rheumatoid arthritis, peripheral neuropathy, pregnancy, and dialysis. Guys, I just put on an air filter, and so if you guys hear that, please let me know and I'll turn it off. Now that I've dealt with the stinky, let me turn it off. Tracy said, Jill, are you familiar with pudendal neuralgia? Yes, I am, because I have pudendal neuralgia on my left side. I got this shortly after being diagnosed with IC. Nothing seems to help. Gabapentin, Botox, stem cells. I'm in terrible pain. So Tracy, have they identified the location where the nerve is compromised? Did they do a nerve block? And if they did the nerve block, what nerve was it? So for me, mine manifested one day. I'd worked a very long time, been working all week on the IC network, sitting for a long period of time. And then I got out of this chair and I went and I was sitting in my living room, and I was actually sitting on a pillow on the floor working on a laptop, and I started feeling a vibration. And I just like, okay, that's weird. But I didn't really pay attention to it. And like a half an hour later, it got worse and worse and worse and worse. And that was what they told me, is that, how can I describe this? Let me describe this. Let me see if I can do this. So if we were to look at the side of your pelvis, looking from the side, looking at where the nerves go, we know the nerves go off the spinal cord, and then they go down into the pelvis and down the legs. What a lot of people don't realize is that there's a little spur that kind of curls back into the butt cheek. And it's this little spur that can easily get hurt if you sit for long periods of time. So we did nerve blocks for me. They never were able to numb that spot. It was always like an inch to the left or an inch to the right. What worked for me was a couple of things. Number one, pelvic floor physical therapy. I had to work on those muscles because they were the ones squeezing the nerve. And then number two, using topical lidocaine on that skin was very important for silencing the nerves in the skin that were hurting so much. And then number three, I use PEA. I use palmitoethanolamide. And that's what keeps my skin and everything else really quite happy. I mean, I'm healthier now than I was in my 20s. In my 20s, I was just in my 20s and 30s and 40s. Well, 20s and 30s mostly. My body was chaos. Now everything's peaceful and quiet, and I think it's related to calming the nerves down, letting go of the anxiety, which is absolutely intensifying everything, and trying to keep those nerves and muscles healthy now. And understanding that it was never my fault. You know, you carry a lot of guilt. You think you're at fault. And when you learn that you're not at fault, that you were actually hurt, it really puts it into context and it helps you make better decisions. So Tracy, have you done pelvic floor physical therapy? I mean, so you're getting an MRI and you're going to an interventional radiologist, so that's great. But in the end, what's the health of your muscles, hon? Because pudendal neuralgia, I mean, unless you suffered a direct injury to the nerve, like jamming your crotch on the bar of a bicycle really, really badly, pudendal neuralgia is really normally driven by consistently tight muscles squeezing nerves. Well, okay, but when you went to physical therapy, what did they say about your muscles? Were they normal or were they tight? And is it on one side or the other side? Where is it? Jennifer says pudendal nerve blocks. Any thought? Pudendal nerve blocks are absolutely viable. They will help identify which nerve is messed up. And so nerve blocks are certainly reasonable things to do. I've had 2 of them. They're a little odd because for me, they did them through my vaginal wall. But it was a good experiment to see if it was helpful or not. But in the end, it was really all about my muscle health. And my muscles on my pudendal neuralgia is on my left side. My muscles that are the tightest are on my left side because I have a bad SI joint there. It's an old tennis injury. So as long as my SI joint is loose, my muscles have to stay tight. Okay, so you have a hypertonic pelvic floor straight down my pubic bone, the center of the pubic bone. So, how long were you in physical therapy? And let me get my model here. I always hate standing up doing these because I never know what I'm going to look on the backside. Hopefully it's not icky. Anyway, we all have our insecurities, right? Tracy said, it feels like someone is crushing my pubic bone. All right, so Tracy, let us ponder the pubic bone for a moment. So here we go. Here are your hips. Let's look at the back first. So we have our spine and our vertebrae. I had trouble remembering that word on Friday. Then we have a triangular piece of bone right here called your sacrum. And notice the holes here. These are holes that nerves emerge from and go into the pelvis. These holes are where the pudendal nerve originate. You can see your tailbone. And I want you to notice, the tail is interesting. The tail, our tailbone helps us balance. It is a centering, anchoring point. And so look at everything, all the muscles and stuff that are attached to the tailbone. So if you have a tailbone that's crooked, if you have a tailbone that comes outwards rather than inwards, believe me, you're going to have problems with your muscles. We know to ask about tailbone injuries, and it's amazing the number of patients who have tailbone injuries. I broke my tailbone, and I can feel the tip of my tailbone. It's the little bit that's sticking out that's a hard lump, right? But let's turn it around to the front. So Tracy, these are your pubic bones, plural. You have a bone on the left side and you have a bone on the right side. And in the middle, they're connected. This is your pubic symphysis. So I have to wonder, did this start after having a baby? Because sometimes what happens is the bones this becomes damaged, and in some cases it starts to open, and that's agony. And it is a potential complication of having a baby. Have they done a CAT scan and looked at your bones? Okay, but remember, all IC means is that you have chronic pelvic pain. Our new AUA guidelines are very clear. They say IC is not a bladder disease. We don't think of IC as a bladder disease anymore. We think of IC as a pelvic pain syndrome. Why? Because structures outside of the bladder are involved. For most of us, it's actually the rare patient who only has a bladder issue like Hunner's lesions. Most of us have other things going on, like tight muscles, a bad tailbone, ruptured disc, fibroid tumors, etc., etc. So, it would be nice to know what your IC subtype is, because it could be that you've had, we know you've got very, very tight muscles. So your IC subtype 3 pelvic floor driven. And tight muscles are devastating because here, let me show you the muscles here. So let's look at this for a moment. So the muscles they're normally flat along the bone surfaces. These are not thick, meaty muscles. These are thinner muscles, but they're still skeletal muscles, but they live at the base of your pelvis and they go up the side. So you see, look, if I stick my finger in here, I can just barely reach these muscles up here. These are the muscles that help you walk and help you open your legs and close your legs, et cetera, et cetera. So we've got a lot of muscles and they're matched on both sides. But see, even here towards the front, look at how high that goes, way up there. So the problem is that when these muscles get tight, they lift off of the area. So think about it this way. Normally, okay, this is terrible because I don't even have my biceps anymore. But normally our muscles are long and lean until you tighten them. Oh, look, I have a little bicep, right? So this muscle is normally flat unless they're in tension. And when it's in tension, it contracts. So when you have tension in the pelvic floor, it's contracting up and it starts interfering with other things. The other thing you got to remember is that you've got nerves going through this area, you've got blood vessels going through this area, and you've got organs in this area. If we look, for example, at our outer muscles, the outermost muscles, these are called the levator ani muscles. And so here they are. These are the shallowest muscles. And so you can see we have muscles around the urethra right here, muscles around the uterus, and muscles around the rectum. And usually everybody at one point in time in their life gets really badly constipated and they strain really hard, and after you're done, you're going, oh, that doesn't feel very good because you have strained your levator ani muscles. So, the consequence of tight muscles down here is hard, because if you got tight muscles around your urethra, it's going to be hard to pee. If you got tight muscles around your rectum, it's going to be hard to have a bowel movement. If you got tight muscles around your around your vagina, it's going to be hard to get a penis in there. That's an issue. And so my guess, hon, is that you have suffered. How long have you had these symptoms? Going back to even IC, how old are you now and how long have you had these symptoms? Has it been for your whole life? Has it been for the last couple of years? When did this all start for you? 1 year ago. And how old are you, hon? You don't have to give the exact year. Just give me like an approximate. I would like to, for people whose symptoms begin, okay, you're 51 and it started at the age of 50. So you go back a year and tell me what was happening a year ago. Were you in an accident? Did you fall? Did anything happen a year ago when this all began for you? Lori makes a very good point. Her doctor gave her vaginal Valium because her muscles were so tight, along with the pubic bone pain. Then she was able to do pelvic floor after that. So again, Tracy, we're going back to right before your symptoms began. Did anything happen back then? Did you have COVID? Did you fall? Were you in a car accident? Painful sex? Did anything happen? No, well, no. Okay, but the flare is okay. So you're saying that the pubic pain started a year ago? When did your IC start? Help us understand the timeline here. When did you first have bladder issues? Like 5 years ago, 10 years ago, 20 years ago, a year ago? When did you first notice more frequency, urgency? Okay, but when? I know peeing cut last, but when did this start? Okay, so you first had your bladder symptoms in May of 2021, and in June you had your pelvic symptoms. So I want you to go back to April of last year. Was there any trauma that happened? Did you fall? Did you take a trip, a long car ride? Were you riding bicycles? Can you remember any physical trauma? I know it feels like your bladder. It felt like my bladder to me too. Horrible work stress. Okay. Okay. So, that's not uncommon. So let's think about this for a moment. You're not the only one who has had symptoms begin after being in a horrible job. I was in a horrible job too when my bladder symptoms began. And I am ashamed to say there were moments when I kind of hoped that I had an issue so I wouldn't have to go to work. I had a real bully at work, my boss, who was just terrible, like worst boss ever. So what we know is that if you're living with extreme stress at work, so let's just say you have a bully at work. So every single time you go to work, you are going into fight or flight because somebody there is trying to hurt you, right? And the closer you get to work, the worse it gets. You become very, very hyper vigilant. As soon as you walk in the door, you're like looking around. Where is she? Oh, I got to stay out of her way. Where is she? Right? So, this is the most primitive part of your brain. There, you can't think yourself out of this. Your brain literally thinks that it is trying to fight for your life, and it's preparing you to fight for your life. And so what's happening is you're going into pelvic floor tension because it's tightening your muscles to help you run. You're going into a higher heart rate and a higher blood pressure because the sympathetic nervous system is preparing you to fight or flight. Remember, our nervous system was built for 100,000 years ago. It wasn't built for today's workload with ridiculous, terribly trained managers. And so we have the same reaction in the workplace that we had 20,000 years ago running from a saber-toothed tiger. Your muscles get tight, your blood pressure goes up, et cetera, et cetera. So the question then is, the longer you're in the stress, the more tight your muscles become. And then the anxiety, again, this primitive part of your brain is trying to get your attention because it thinks your life is at stake. And so what it's actually doing is it's intensifying the pain. It's intensifying the symptoms. That's what fight or flight does. And when you're in fight or flight for an extended period of time, you go into pelvic floor tension. Now, but you have no idea you have pelvic floor tension. Your very first symptom is frequency urgency. And you're going, it's my bladder. And you call your doctor and you say, hey, I think I got a UTI. And the doctor goes, okay, here's some antibiotics, but they don't work. And you go back to the doctor and the doctor goes, okay, let's do long-term antibiotics, but they don't work. You do them for 6 months or a year. You end up with yeast infections, but they don't fix it. You go back to the doctor, you're still not sleeping at night. You're still getting up to pee. Your doctor eventually goes, well, maybe you have overactive bladder, and they give you those meds. They don't work. And eventually you go back to the doctor crying in pain. And the doctor goes, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. Well, our new AUA guidelines refute that. They say, no, this is not an incurable bladder disease. This is a pelvic pain syndrome characterized for many of us by very, very tight muscles and nerves that are compromised because of tight muscles and previous trauma. So we've stepped away from the concept of disease, and now we're focusing on the concept of injury or trauma. And so, you were on antibiotics for 1 month, 4 different antibiotics. And Tracy, the other issue here is your age. So in addition to you living with constant muscle tension, you are also now in estrogen atrophy at the age of 51. And so you are losing that nice, thick protective coating that normally protects your bladder, this area right here. This is your mucosal barrier. And this is, remember, your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. The purpose of the mucus is to protect the tissue. Unfortunately, it's estrogen dependent. So when you're young, you have lots of estrogen, you have lots of mucus, and your bladder can defend itself. But honey, at the age of 51, you do not have the estrogen you used to have. So now you're going to be in estrogen atrophy. And so now some of the irritants in your urine are now going to reach down here. And they're going to give you the symptoms of frequency, urgency, pressure, pain. But your culture is negative because it's not necessarily bacterial. It's more of a chemical injury. So we've got, you have a double-edged sword here. You are absolutely at the age of estrogen atrophy. That's why it feels like you're peeing cut glass. That's exactly what it felt like for me. Your urethra is kind of the canary in the coal mine in the sense that it's the first part of the urinary tract to start screaming when your estrogen levels drop. So if you're struggling with more urethral pain, that makes sense. You always want to have your doctor look at the quality and health of your skin. And let's make sure your skin is good and healthy. And if it's not, they would normally give you a topical estrogen. But the other hard reality is that your muscles are toast right now. Your muscles are toast. And if we look along the inside, so here's your pubic bone right here, and we've got muscle attachments right here. And so what are the muscles doing to the bone? I'm really glad you're going to have the MRI. I think that's really good. That's really good. Let's get a real good picture here. I had another member of the IC network, just like you, terrible pubic pain. And what they found was that her pubic bones were actually detached. So every time she walked, these bones were not connected anymore. Severe pubic symphysis. So I like the MRI. I think you definitely should get the MRI, but we need to get somebody to look at your skin, and that pelvic floor physical therapy is important. The other thing you might really benefit from is this. You know, let me look at this here too. So this is the Bible when it comes to muscle bone issues. Breaking Through Chronic Pelvic Pain. Phenomenal book. Best book ever written, in my opinion. It's wonderful. So if you really want to try to understand your anatomy and where the muscles are, where the nerves are, and what happens, all the problems that can cause to your bladder and your bowel and all sorts of stuff, and pudendal neuralgia. This is a great book for pudendal neuralgia. It explains it perfectly. I would encourage you to get that book so that as you're laying on the table, as a physical therapist is working on you, you can visualize what they're touching. But the other thing you've got to ask your physical therapist, and this is something that he really, so Dr. Wise was a urologist back in the 80s who saw the bladder therapies didn't work, and he wanted to know why. And so he became one of the nation's first muscle specialists. Very humble guy, not a cocky bone in this gentleman's body. He wanted to learn. He wanted to understand. And so he became an expert in muscles. He looked beyond the bladder. And if you go back 100 years and you look at the IC papers, they all describe tight muscles. But again, urologists play in the urinary tract. They acknowledged that there were tight muscles. They didn't do anything about it. Well, now we know that the tight muscles are a huge part of the problem. So anyway, he became an expert at muscles. He became an expert working with muscles, hands-on work, hands-on massage, trigger point relief. If you walked in his office in San Francisco with tight muscles, I could promise you would walk out with muscles in better condition because he was so good with his hands. But what baffled him were the patients who called back a week later or a month later and said, it's back. And he's like, how is that possible? We got rid of your trigger point. How could your trigger point be back in exactly the same spot? And that's when he started looking at bones. He goes, well, what puts long-term chronic pressure on muscles but bones? So if you have one leg longer than the other, your pelvis is going to be tilted to the side, right? So if one leg is longer than the other, then you might be walking like this, right? Or you could, like me, have a bad SI joint, and the muscles that are trying to keep this together are staying in a tension pattern. So the really important question that you need to ask your physical therapist is, are the muscles staying tight? Because if the muscles are consistently staying tight, then we've got to broaden our scope and try to figure out why. And generally, that's when we start looking at bones. Do you have a bad hip, a bad SI joint, a bad knee, a bad foot, something like that? Well, this is great. Dr. Eckenberg is one of your doctors. He is, in my opinion, the best pelvic pain doctor in the country. And so if you're under Dr. Eckenberg's care, that's fantastic. I think he's a wonderful, wonderful doctor who's trying to train a lot of other doctors. And you know, when you go see Dr. Eckenberg, you got that massive intake form to fill out. He's not like other doctors, man. He wants to know everything. He studies your case before he talks to you. And you are asked to fill out a lot of questionnaires so he can really try to understand the totality of your pelvis and your body and your symptoms, because he's trying to visualize. It's a really good podcast with Dr. Evans over on Callie's podcast, Callie Krugier's podcast. She did a wonderful 2-episode podcast with Dr. Evans. I would encourage everybody to watch. I've gotten through one. I want to get through the second, and I'm going to write an article on it. Yeah, he's wonderful. But I'm going to bet that you have a detachment with your pubic bones in some way. Something's not right there for that level of pain that you're having with your pubic bone, that crushing pain. When are you going to have your MRI? Is it going to be in the next couple of weeks? Next week. Awesome. So, listen, with the MRI, have you ever had an MRI before? Well, okay. So let's just talk about the MRI for a moment. So with the MRI, you're gonna be laying on your back, and they're gonna put you into a tube-like machine. And although there are some machines that are standing up machines, which are perfect, there are some machines that are big tubes, and then there are some machines that are kind of narrow tubes where you go in, and if you open your eyes, like literally the top of the machine is right here. So it can be, if you tend to be claustrophobic, it can be a little bit challenging. I had it done. So I'll tell you exactly what I did with my MRI. I had my MRI a year and a half ago for my lower back when I ruptured my disc. So it's not going to be up by your head. It's down low, but you still might be in the machine a little bit, but it's okay. A little bit of Valium on board, recommend. I took 1 5 milligram Valium. It kept me chill. And then the other thing about the MRI is it's really loud. It's like 20 minutes, and you kind of move back and forth, and then you've got loud clacking that occurs. And so it's the perfect test because it's a 3-dimensional test. It will let them look at everything. I don't regret it one bit. With that little bit of Valium on board, it was fine. What I did is I did a couple of different meditations while I was doing it. So I did my I Spy, which I've done several times in here, where you give your body good, you imagine looking at something that makes you smile, imagine smelling something that makes you smile, hearing something. It's just to try to keep your brain calm and collected. Obviously, a little bit of deep breathing. I did a chakra meditation, which is a color meditation, which is, a little bit out there for some people, but it works for me. But in the end, I just counted by sevens, 7, 14, 21, 28. And as long as I counted, I was fine. If I stopped counting, I started getting a little anxious. So it's just like, all right, I'm going to count. And I got up to like 500 and something. And then we were done. And it was invaluable. So I don't want you to go there and get freaked out about it. There's no reason to be freaked out about it. They do MRIs every day. Millions of people have had them done. But it's a different type of test. It's a little bit weird. It doesn't hurt. There's nothing about it that hurts at all. They're not touching your body at all. They just slide you into this machine. The machine spins around. It makes a lot of noise, and they pull you back out. Okay. So you can do it, my dear. You can do it. I got through it. If I can get through it, you can get through it. The newest machines are quieter. It's the older machines that are louder. So with any luck, the machine, especially if you're with Dr. Eckenberg, and you can call his clinic and ask him, is there anything I should do to prepare for this? What would you recommend? For all we know, you're going to be in a state-of-the-art MRI machine, and you're not going to have any issues at all. So just, be prepared. Do a little bit of research on it, and just bring some good self-help skills to just kind of walk you through it. And for me, it was counting by sevens. If I just did that, I was fine. All right. Lori says, what state is Eckenberg in? He's in Bethlehem, Pennsylvania. Tracy, what do you do for pubic symphysis? You can, I would encourage you to Google it. There are lots of different things you can do up to a point. I mean, keeping your knees. So again, if your hip bones are moving, if your pubic bones are being kind of forced open, that's where the pain comes from. And so they have you put your legs together when you're getting in and out of a car or sitting down, because that will keep stress from the pubic symphysis. They might have you do warm compresses, all sorts of stuff like that. Google it, you'll find it. But if it's a bad, let's just say it's particularly aggressive, then they might need to do a little bit more. You might wear an SI belt to kind of just hold everything together a little bit, or they might even recommend surgery. It just depends upon what they see. So don't freak out about it. Listen, I'm not God. I can't predict the future. You're not God. You can't predict the future. For all we know, what they're going to find is a very, very mild case with very, very simple things. But pubic symphysis, certainly, and it says it can take 3 to 8 months to heal on its own. For most women, the pain and discomfort can linger for about 2 months after childbirth. And you can find lots of exercises on it. And you know what? I have another book. Hold on. This book, Ending Pain in Pregnancy by Isa Herrera. Let's see what she says about it. If she does. So it's cartilage. It's a cartilaginous joint between two pubic bones. It connects the two bones. And let's just see what she says in here. Oh man, it's lots and lots and lots of pages. This is another book that I think is exceptional called Facing Pelvic Pain. Let us look at this. No, it's not covered in that book. I think you're going to have to Google it, my dear. Oh, life, right? It's crazy. It's crazy the things that can happen to us. I always thought, didn't you always think when you were young that life would get easier as we got older? Yeah. Just get a little bit more complex. Gloria says they can talk to you through the test by telling you how long each session of the MRI is. Yes. And some can even pipe in music and, book on tape, stuff like that. So, be bold, my friend. Ask for help, ask for support. It's understand that MRIs are not the funnest thing in the world, but they're not torture. They're pretty short overall. If you can have a tooth filled, you can have an MRI. But they always have little tips and strategies. So if they can play music, that would be great. If they have headphones, that would be great. It just depends on what they have. Hello, Scott. Are you a pelvic pain patient, Scott? Have I talked to you before? You have to bear with my memory here. I work with so many patients. It's just impossible to remember everybody. Yes, you had pelvic. Oh, you're new. All right, cool. So my friend told me about you. Oh, that's sweet. Thank you. Yeah, my specialty is kind of working with men and women with pelvic pain, but especially men, because My first support group that I started years ago was filled with men. And let me just offer you this. The barrier that men face is that you are often labeled with chronic prostatitis when it's not chronic prostatitis. Anytime a man has frequency urgency pressure pain, they almost always assume it's prostate, give you meds and all that sort of stuff. And in my clinic, well, clinic is the wrong word, in my office, because I don't provide direct patient care. I work with patients on the phone. I'm a coach. I'm a wellness coach, but I'm a support group leader. In my office, 90% of the men that I work with are absolute pelvic injury patients. We can always find pelvic trauma, a history of pelvic trauma. So were you a bike rider? Were you a football player? Were you in the Army? Were you a paratrooper? Can you remember any trauma? Were you an athlete? So the chronic rectal pressure issue is always going to be this muscle group, which is going to be your levator ani muscle around your rectum. Used to work out a lot. And were you a weightlifter? What were your workouts? Did you do a lot of squats, weights on your shoulder, stuff like that? Did a lot of leg exercises. So, and a lot, okay, so it's the heavy lifting that's going to put tremendous pressure on your pelvic floor. So let me share the story of a gentleman that I mean, I've worked with so many men. I work with them almost every day. But I had, oh, you were actually trying to fix a patellar tendinosis issue. Interesting. I had a gentleman call who was an Ironman athlete. And I'm not talking just a basic Ironman. We're talking a Hawaii Ironman elite athlete. And one day, out of the blue, bam, all these symptoms: pelvic pain, pain with urination, pain with bowel movement, you name it, he had it. And his primary care doctor was just, it's infection. They gave him antibiotics for a long time, didn't work. And it got worse and worse and worse. And of course, nobody really ever asked him if he was an athlete. And so after a year or so, he was just being tortured, for lack of a better term. He was just in terrible, terrible shape. It was actually his mother who called me first, and then I ended up talking with him. And so we were kind of going over his symptoms, and his symptoms were all muscle driven. He wasn't having the typical bladder wall symptom. He was having, he was having very clear muscle symptoms. He couldn't start to urinate easily. He was having trouble with bowel movements, et cetera, et cetera. This was 5-6 years ago, so I might have some of the details, but I just say my immediate, in talking with him, he sounded like he was muscle driven. So I was like, so what do you do? And he goes, well, I'm an Ironman athlete. And I'm like, okay, so how many miles a week do you put on your bike? And he's like, I think it was 50. Now, he was in his late 30s, and he'd been an athlete for 20 years. He'd been doing that for, putting pressure on those pelvic floor muscles for well over 20 years through his bicycle seat. And if we look at our pelvic cavity here, you can see the bicycle seat goes right into muscle and nerve. There's no bones. The narrow neck of the bicycle seat pushes right up into muscles. The human body was not designed for that. That's why we call this bike rider syndrome. It's incredibly common to have a muscle issue. And so anyway, so we talked about that, but he didn't believe me. He goes, no, it's my bladder. It's got to be my bladder. I'm peeing all the time. So, he just didn't believe me. They called me back a couple months later. It's in terrible shape. I went, did you get your muscle checked? He goes, no. Hung up the phone. Called me back. Jill, I don't know what to do. It's so bad. Please help me. I'm like, have you had your muscle checked? He goes, no, I don't believe you. It's my prostate or my bladder. And I'm like, what the hell do you have to lose? Go get your muscles checked. And he was angry at me, hung up the phone. But he finally went and had his muscle checked and at a university. And he called me from the car and he goes, oh my God, you were right. I have a severe muscle injury. And I was like, yes, you do. And now the great news here is we know what to do. Now we know why the antibiotics didn't work. Now we know why the prostate meds didn't work. So it was all about working with those muscles. Now, will he ever be able to ride bicycles for a long period of time again? Probably. I don't know. Because that's a lot of stress on those muscles. So Scott, you kind of did the same thing, only you were putting different stresses on those muscles. Have you had a pelvic, and the fact that you're having issues emptying your bladder? You know, if you can't start your stream right away, if you're hesitating 5, 10, 15, 20, 30 seconds before you can pee, hon, your muscles are tight. If you're having issues with bowel movements, your muscles are tight. So have you had a pelvic floor assessment? That's what you need to have. We need to get a sense of what's going on with those muscles. Kate says, can I call you and book an appointment? Yeah, absolutely. I would love to talk with you. I would absolutely love to talk with you, Kate. And tomorrow I'm dealing with mother issues. We're having home visits for her issues, so I'm not going to be available much tomorrow. But if you want to email me, my email is icnetwork@mac.com. You can email me your phone number, and if I have a chance to call tomorrow, I will. I just have to put my mom first. And then Tuesday, I will be available in the afternoon, and then I'm open all week. All right, so Scott, so what are you doing about the tight muscles? What are you doing about those tight muscles? Are you doing physical therapy? Kate, Kate, that would be fine, hon. You email me right now. I mean, if I have time after we're done, I'll call you today. It's not a problem. I just, it's just always a balancing thing because I've got elderly parents who need me too. But please email me, icnetwork@mac.com. That's M as in Mary, A as in Apple, C as in Charlie. And we'll try to connect. And guys, remember, I'm not a doctor. I can't give you clinical advice or medical advice. My job is to educate you, inform you, open up some new doors, and then kick you in the butt and get you back to your doctor with a new set of questions. All right, so Scott, what are you doing about those tight muscles? Kayleen, girl? Ooh. Okay, hon. I'd be happy to, Kayleen. We'll connect. Okay, so Scott had an anal fissure. Holy hell, mother of God, those hurt. So you did much less walking as walking caused the fissure flares. Your muscles decondition. So Scott, the question that you've got to ask your physical therapist is, are your muscles returning to tension? Are we seeing a slow but steady improvement in your muscle tone, or are they always reverting back to tension? That's good. I would, Scott, really, seriously, you need this book. And it's free on Kindle Unlimited. I'm not trying to sell you a book. I'm just telling you, this is the book that will help you understand what's going on right now. Every diagram is for men and women. They've got male anatomy, female anatomy, and it will help you. Oh, you have the book? Cool. Okay. Good. It's excellent. I mean, but you're back in college. You got to learn the anatomy, and you got to go back and refresh your memory. I've read it 2 or 3 times now, and I still go back. Every time I read it, I learn something new. Just know that it's not just the walking, and it's not just the stretching. So like my physical, so when my problem started, they blamed it on a torn muscle on my left side. And my physical therapist at Kaiser, everybody was saying, you need to stretch, you need to stretch, you need to stretch. And so for 10 years, believe me, I stretched. I'm so flexible now. I can touch my nose to the ground when I'm sitting on the ground. I'm so flexible. But the problem is I just got worse and worse and worse. I went from being able to sit for 2 hours to being able to sit for 10 minutes before it hurt, doing all this stretching. It didn't fix it at all in any way, in any way, shape, or form. I was not better. And so I finally was like, Jill, you were an athlete. I was a major athlete. I'm like, I'm going to go to an athletic trainer. And my Kaiser physical therapist said, I don't think we're going to be able to help you. You need to go here. Let's see what they have to say. And so I went to a physical therapist that worked with all the regional football teams and all the major athletes and the elite athletes. And he just so happened to be the physical therapist for the Olympic tennis team years ago. He was also worked on Yvonne Lendl, who had exactly the same injury that I had. And he's the one who helped me understand it's these are tennis injuries for you. But anyway, he had me walk up and down the hallway, and he goes, huh? I'm like, what? He goes, do you realize you don't walk straight? And I'm like, no, I'm walking straight. He goes, no, you're not. You're walking like this. You're favoring one side very subtly, right? So instead of walking straight, you walk like this. And I'm like, no, I've never noticed that. I go, let me walk up and down again. He goes, no, you're doing it. And then we went in, he started the exam, and he goes, it's your SI joint. This has nothing to do with your muscle. I mean, it's your muscles, but the underlying problem is your freaking joint. Your joint's messed up. Because this is what happens to tennis players. You're right-handed, you put your weight on your left foot, your left SI joint gets too flexible and weak. Classic tennis injury. And then I showed him what I was doing. And he yelled at me. He goes, stop immediately. Never do that again. Do not stretch that way ever again. And I'm like, that's what I've done for 10 years. He goes, you have so overstretched the muscle now that the muscle isn't even activating. So when I was walking, my right side was doing all the work. My left glute muscles were not even carrying the weight because I had so overstretched them. So he said, no more stretching, no more yoga. You need Pilates. Pilates is the way to go. And that was a real big learning lesson for me. It says, I know about trigger points. I've tried to release them, but I can get so easily flared up by certain trigger work on the muscles. So flares can last much of the next day. I plan to go back to it at some point, but I've just been struggling so much with my mental state and the bodily discomfort from the flares. I also get flared up by sexual release. Well, that's because you have, that's when you have your biggest muscle spasm. Do you feel like your physical therapist is good? Are you making progress with the physical therapy at all? And let me check my email here. I do not have an email. Okay, do it again. icnetwork@mac.com. M as in Mary, A as in Apple, C as in Charlie. I do not have an email from you, hon. Let me check this computer. No, and it's not in my junk folder either. So, yeah, no, it's not an L, it's an I, it's an I. IC network. Okay, so you're not seeing a physical therapist, but you're scheduled to see one in July. Dude, you're gonna have to live physical therapy for the next year. I mean, you have to understand that the long-term effect, as he says in the book, the long-term effect of hypertonic muscles is ischemia, oxygen deprivation. These muscles are so tight, they're squeezing blood flow. They're limiting blood flow by squeezing your arteries and veins. So it's very hard for everything to be healthy if it only has half the amount of blood it's supposed to get, or a third of the amount of blood that it's supposed to get. I mean, the bulk of your money has to be focused on muscles. And that internal work, I mean, and of course I know the challenge, the challenge for guys, unfortunately, is that it's rectal, but it has to be rectal because that's the only way that they can reach these muscles, right? But again, I want you to look. Oh, here, hold on. I moved my computer around a little bit. So you can see my finger here, and it's with a finger that you can actually get in and you can go the length of the muscle. Generally, what they do is they go the length of the muscle. Sometimes they'll go crossways around the muscle. If they find a trigger point, they might just gently press and release and press and release that trigger point. Because as long as you have a trigger point, you have long-term muscle dysfunction. So this is about getting these muscles to relax. And again, it's about following the muscle. And it's going to be helpful because Scott, if you give me your email, if you email me too, I have a whole little email that I send to men with 5 blogs written that are cures, men who have been cured with physical therapy. And I am very confident that you're going to see it yourself in these stories of other men who are where you are right now. So if you email me, icnetwork@mac.com, I will send that to you. And I want you to read those blogs. But the bulk of your time, listen, you spend a lot of time getting fit. And you have to remember, like, the concept of muscle memory. So if you gave me a tennis racket and took me out to a tennis court, I will still look like a professional tennis player. My muscles know exactly what to do. They were trained for decades. I know how to hit a freaking tennis ball and look good. It might not go in the court without work, but my muscles know how to swing a tennis racket. It's muscle memory. So the challenge with your workouts is that you reinforced a muscle memory of muscle tension. And now you have to do a workout that will reinforce muscle relaxation because you spent a long time working out just like I did and tweaking those muscles. And the great news here is you're the perfect candidate to get better because you love working out. You understand the value of time. You understand the value of working with those muscles. And now you're going to do it a different way. Instead of strengthening, now we're going to focus on releasing and relaxing. And so generally what they have to do is they have to release the muscle first and then strengthen that weakened muscle if they find that your muscle is weak. And so I feel very confident that things will get better. Okay, but think about it this way. If they touch a muscle and trigger a flare, that's what I call your hallelujah moment. They found it. They found it. Your question now is, what the hell are you touching? Tell me what muscle you're touching so that you can research that muscle and research how to rehabilitate that specific muscle, because every muscle has different exercises. So, when somebody goes for their pelvic floor assessment, the physical therapist's job is to study you externally and internally. They're going to look for tension patterns. They're going to measure your legs. They'll see if one leg's longer than the other. They're going to look at your back and your core and your thighs and your hamstrings. And then they do the rectal exam. And what they're going to do with the rectal exam is they're just going to touch muscle groups. Okay, they're just touching muscle groups. And if they can touch a muscle and trigger your pain, girl, that is your, I mean, you're not a girl, I'm sorry. Dude, I say that with love. I've been talking for it's about 2 hours now. So, and it's Sunday and it's been a long week. So I apologize for calling you girl. I didn't mean to do that. But anyway, if they touch a muscle and trigger pain, that is exciting. That's your hallelujah moment. It's like, what the hell are you touching? What is it? Well, there you go. Now, and now you also say you have feet issue. And so the chapter on the feet in that book is phenomenal. It's phenomenal. For those of us who have long-term chronic muscle tension, you know, we look at bones, we look at the hip, we look at the SI, we look at the knee, but we always have to look at the feet. Because if you're not walking correctly, and that's what Dr. Weiss found, is that 90% of his patients who had long-term recurring muscle tension, they did not walk normally. I have Morton's toe too, and he gives you that you put a little circular pad on your thing. There you go. He tells you exactly what to do with the Morton's toe. And the shoes matter. Hoka's are the dream. Having Hoka shoes are the dream of dreams. Let me go get a pair. Hold on. I got like 6 pairs of them. This is my newest pair. So Hoka shoes are the bomb. They're the absolute bomb. And you can pull out the insert, and you can put that. Look, see, I did it. See it right there? That's my little pad for Morton's toe. Lori says you love Hoka. They're a little expensive, but they last forever, so it's worth every penny. And you can get them on sale. You just wait. They about every 9 months they do the season, and so you can get the older season, and the older season a third of the price. Hoka shoes are a dream. They're the only shoes I wear at work now. Yes, he says, do I think feet issue could have caused pelvic floor? Definitely. That's what he says. Read the chapter. Read the chapter. If you have specifically, Scott, hold on, let me get it. You got it. Whoops, wrong book. Specifically, I want you to go to, hold on, page 146. Okay, page 146, guys, in this book. Or you're on a little delay here, so here, hold on. It's hard because Facebook is on a delay, YouTube isn't. This is a normal ankle. And I want you to look at the position of the leg. It's a straight up 90-degree angle, right? So the shin bone straight up, the femur, you can see goes at a slight angle up to the hip bone. And if I push it in, you can actually see the piriformis muscle right there that kind of attaches it. But now look at the dynamic of what happens if you have an ankle that rolls on the inside. You immediately see distortion in the leg. Now the leg is moving up at an angle, right? And now that's exaggerated even more in the femur. And if you look at a close-up, you can see that the pelvic floor muscles on this side are stretched farther than the pelvic floor muscles on this side, leading to long-term pelvic floor tension and dysfunction. So it literally can be, and he talks about the concept of wear and tear injuries. You know, when you're a kid, when you're a teenager in your 20s, you got a lot of resilience, but there's a reason why athletes are the best when they're kids and in their 20s. By their late 20s, early 30s, things start to break down. We're not as resilient. And that's when we see wear and tear. That's where we see, if somebody had just told me that 10 years of doing Stairmaster would have just, taken my feet pads away, I would never have done it. But I was addicted to, the endorphins. I love working out. That was just me. I loved it. That was peace for me. That was harmony for me. That was where I could get rid of my stresses. I didn't have a clue that I was doing long-term damage to my body. And if I could go back in time, I would have told the 21-year-old Jill, not a good idea. Not a good idea. Let's do something else instead. So with the feet issue, we're talking the ultimate wear and tear, because the feet influence everything all the way up. Your pelvic floor muscles absorb the stresses and shocks from every step you make, every weight you lift. Lori says, me too. I love the endorphins. Yeah. I wasn't so much a team player. I like doing the individual workouts more. I just like to get in there and just push it. And I miss it every day. I'm dying to go to the gym, but I just won't do it. There's very interesting, guys. There was, I get this whole medical feed, right? I'm part of a lot of medical groups, and I got an interesting case about monkeypox. So monkeypox is this new variant of smallpox, which is also has the potential of becoming a bit of a pandemic. It's not usually fatal, and it causes like chickenpox. It can cause red spots and a variety of other symptoms. And they have been focusing on the fact that it appears to be the most contagious through sex. And yet there was a very interesting case study I read yesterday of somebody who worked, he cleaned Airbnbs. So he went and cleaned an Airbnb and changed the sheets, and he got monkeypox. And so, they're talking about, so he just started breaking out in bumps. They're talking about that you have to touch something that's infected, right? And so the take-home message is, if you're caring for anybody else's, like a hotel, anything at all like that, or you're checking in, you want to bring gloves, and you want to bring your own sheets. And thankfully some hotels, especially the higher end hotels, wrap the comforters in sheets. So then they're new every time. But the point is now, what the hell else can happen? Well, unfortunately, now we know what the hell else can happen with what's happened recently from the Supreme Court, which I'm not going to talk about. Scott says, using that patch would be sufficient to fix Morton's toe issue. I wonder if fixing that issue could reduce my muscle tension in my pelvic floor. You got nothing to lose, dude. You got nothing to lose. Give it a shot. I put it in all of them. And my pelvic floor is a lot better now than it was. Like, how long have I been sitting? I haven't tweaked once. I've been sitting here for 2 hours and 43 minutes. And my pelvic floor is fine. When it was at its worst, I couldn't have sat here for 15 minutes without pain. So I feel like it's about addressing every little issue that seems to come up, just being very proactive, right? Gloria, I'd be happy to talk to you if you like, hon. Not a problem. I'm available again Tuesday afternoon through the rest of the week. I should be here, barring fire, earthquake, or family issues. Sherry says, "What about a bunion? Does that bother the pelvic floor when walking?" I don't see how it wouldn't. I would think anything that changes the way your foot hits the ground is going to change and affect your pelvic floor. One of my favorite TV shows to watch. I rarely watch TV, but the two TV shows that I am addicted to is Dr. Pimple Popper and My Feet Are Killing Me. And My Feet Are Killing Me one of the podiatrists, woo, they show all that surgery. And it's amazing what's going on with people's feet. Kate said you sent your number through chat. Okay, try not to do that in the future because now everybody's going to see that. So, Kate, this is what I'm going to do. I'm going to write it down and then I'm going to delete it because I don't want future people. I think there's one extra number. Honey, there's an extra number in there. That's 10 numbers instead of 9 numbers. I mean, no. That's 11 numbers instead of 10 numbers. Look at the last 4 or the last 5. Do I think an infrared heating pad is more effective to relax muscles? My body craves heat. Okay, you're in Australia. Well, that's a whole nother story. We would need to Zoom. Oh. Hold on. I'm a little bit afraid to change my screen because I might accidentally disconnect this chat. You know, Kate, what I can do right now, if you want, is we can just open up a Zoom. I can open up the ICN Zoom room if you want to come in. Why don't we do that? Here, let me turn on the Zoom room. Now the challenge is that other people can come in, and so if you want to talk about personal issues, that's a whole nother story. Okay, hold on. Let me open up the Zoom meeting. Hold on. Or we could even go into Discord. Do you have Discord? Hold on. I mean, you know, we used to do Zooms all the time. I just got a little overwhelmed. Okay, hold on. Let me open up Zoom. Okay, hold on. It's on. Okay. No, let's do. Okay, that's have Zoom, right? You can do Zoom. Can you do Zoom right now? Joni says, great info. If a hydrocysto showed mast cells, what could be the cause? Allergy, something tweaking you down there, but that shows that using the antihistamine would be reasonable for you. All right, hold on a sec. Hold on. HJY6HU. Let me just, because I'm working in front of two computers. I got to get into the right meeting. Okay, so okay. Hold on. Give me a moment. I have to coordinate it on two separate computers. And this one computer doesn't want to do it. It says the host has another meeting in progress. Yes. I've started the meeting on the YouTube computer. Arg. This computer. Okay, so the Zoom room is I'm going to give you the number. All right. No. No, let's just do it now. Let's just do it now. Okay, so if you go to Zoom, the meeting number is 676-119-1823. 676-119-1823. And the password is 8JY6HU. 8JY6HU. Okay, so on Facebook, I can't cut and paste because you're on a completely separate computer and it's not letting me do it. Here on YouTube, I don't know. My sound went out. Okay. Okay. All right, so Scott's come in. Cool. Kayleen can't. That's okay, honey. Yeah, I can hear you, Scott. Scott, hold on one sec, because everybody can hear you, so give me a moment.
Okay.
Kayleen, call me this week, okay? Okay, I just want to make sure Kate can get in. Anybody else? And if anybody else wants to come into Zoom, You've got the credentials. Otherwise, so let's just give Kate a moment. I don't know who that is. Oppo Find X3 Lite 5G. Who is that?
Jill, can you hear me?
Yes, is that you, Kate?
It is. Thank you so much for doing this. I really appreciate it.
Okay, all right. So you guys hold tight now. So for everybody on Facebook and YouTube, we're done for the day. I'm gonna wish you well, sending you all my love. If you have questions, you know who to call. You can reach me at the IC Network. We have an 800 phone number. Believe it or not, I do answer the corporate line and the patient support line. If you find these meetings, please think about becoming a member so you get our magazine, all right? And that supports us. You can come on over to our store, get the books, et cetera, et cetera. But we're now going to go do some one-on-one work with people who really need us. So I'm going to say goodbye to Facebook. All righty. And we're going to say YouTube, same thing for you guys. Y'all, I wish you the best. Y'all have a good week. And we will talk to you again. All right. So those are now